I think this group certainly understands just how aggressive and universally fatal glioblastoma is. I think what I wanted to remind everyone is just how little innovation there's been in the frontline setting, and point out that even the standard of care using temozolomide, that really only works for about 30 to 40% of patients, but that's still the standard of care. The Optune helmet, showed an improvement in a phase 3 trial, but if you speak with a lot of neuro-oncologists, there's still quite a bit of skepticism. And then I think, as many are aware, the checkpoint inhibitors that have proven so effective in some peripheral solid tumors like melanoma or lung cancer, they've been evaluated in multiple phase 3 studies, and had no impact. So there is a huge need for these patients. Now, cancer vaccines have been around for literally decades. There have been literally dozens of vaccine trials used in both the primary and recurrent GBM settings, and they have universally failed. And until a few years ago, it really was a dirty word. There was so much negative data that I think, rightly so, the vast majority of people believe that they would never work. But very recently, using neoantigen approach, combining mRNA encoded neoantigens produced by Moderna with Pembro. This is a trial, and you can see here, this is, sorry, can you see my cursor?
Yes.
Yeah, okay, great. So this is Pembro alone, and this is when you add this personalized neoantigen-specific vaccine, and you can see there was a very clear improvement in efficacy in terms of survival. So the point here is that cancer vaccines can work. It's just that we've spent literally 20 years using, in the vast majority of cases, self-antigens that are very poorly immunogenic. So it's all about the target. So a little over 2 decades ago, Charles Cobbs and colleagues stumbled on this observation that there are viral antigens, specifically from cytomegalovirus, or CMV, that look to be uniquely expressed in primary glioblastoma. And you can see it highlighted here. He used a variety of techniques, whether it be immunohistochemical staining against some of the major antigens like PP65 or IE1, and then used in situ hybridization. Critically, it really was specific to the tumors, not in inflamed or normal appearing white matter. Several years later, John Sampson and Dwayne Mitchell and colleagues confirmed this data, and that's highlighted there below. Now, what's shown here on top is just to give you a sense of what the staining looks like. So you can see here control staining, and then here in brown staining against PP65. It's important to emphasize that it wasn't just a sporadic tumor here or there that looked to be positive for the antigens. It really was pretty uniform staining. Now, having said that, if you do a PubMed search, you will find a variety of groups that have not been able to replicate the data. So I think there's 6 or 7 by my last count that could, but certainly some that haven't. And so there has been some skepticism. These are technically challenging assays to run, so that could certainly explain why some have failed to do so. But before we decided to launch a clinical study, we wanted to really try to come at it from another way. And so this is another paper. So instead of using immunohistochemistry or in situ hybridization, you can ask it immunologically. So here are 4 different patients. The study investigators generated CMV PP65 specific T cells. And then what they did is a traditional chromium release assay where, going from left to right, they added increasing numbers of these T cells to a variety of different targets. Now, what's shown in black, these are the patient's autologous dendritic cells loaded with CMV RNA. So they're antigen positive. As you increase the number of T cells, going from left to right, you can see in every case a nice dose-dependent increase in cytotoxicity. What's shown here in the white symbols for each of these patients are there tumor cells? And you can see again, nice dose-dependent killing, and the controls were all fine. So this is demonstrating from a very different assay, using an immunological assay, that it really does look like the CMV antigens are there. And perhaps even more importantly, it emphasizes that they're there being presented by HLA at levels that the T cells can recognize. Now, at this point, there have been at least 6 different clinical studies, caveat being that they're all small open label studies, but in a variety of different ways, they've all suggested that clinically targeting CMV in primary or recurrent GBM could prove to be efficacious. I won't go through all these studies, but I will emphasize 2 of them. If you look at this one at the top, this was done at UCLA, Tim Clousy's group. They, as many have done in the past, took GBM cells, made a tumor cell lysate, pulsed autologous dendritic cells, and vaccinated. And what they discovered is that there was a dramatic 20-fold increase in the frequency of CMV-specific T cells, strongly implying that there must have been CMV antigens present in that tumor cell lysate to expand those T cells. And then most recently, the group down at MD Anderson generated autologous CMV PP65 specific T cells. They infused them into patients with recurrent GBM, and you can see there was 1 complete response and a couple partial responses, and then several cases of stable disease. It's difficult to understand how you would have a rapidly growing recurrent GBM completely be eliminated or reduced by greater than 50% if the antigens weren't there. So collectively, aware of all this data, my former company decided to launch a clinical study targeting CMV for recurrent GBM. Now, this just summarizes, 4 different aspects that we thought were shortcomings of past efforts. The first is I've already implied, it was the choice of the antigen. Rather than going after overexpressed self-antigens, we want to go after a viral antigen like CMV. You're asking the immune system to do exactly what it wants to, fight a virus, only in this case, in doing so, potentially fighting a tumor cell. There's also, over the past couple decades, been an almost myopic focus on the importance of CD8 positive T cells, but there is a tremendous amount of both preclinical and clinical data showing that if you want sustained activity and persistence of those CD8 positive T cells, you need to have a CD4 compartment and response as well. So if you look at people naturally infected and that have recovered from CMV, the number 1 CD8 target is the PP65 antigen. The number 1 CD4 target is against a protein called GB. So what we did is we decided to incorporate both of those antigens into our vaccine construct. And then another limitation has been that in many studies, investigators have used short peptides, either single peptides or just a couple of them. And there's a real concern, given the heterogeneity of the tumor cells and the ability to select for tumors that no longer express the target. We want to have very broad repertoires of both CD4s and CD8s. So we express the full-length proteins, knowing that each individual's HLA would be able to process and present them, and moreover that we would have at least 3 to 4 different epitopes in each one of those antigens. And then finally, these are patients that, as I'm sure you're all aware, are really not very immunologically fit, either through the disease course or through some of the treatment regimens that they've been subjected to. So the immunogenicity of the vaccine delivery has been a real issue in many past efforts. Arguably, the most successful vaccine approach has been the use of dendritic cells because they are the best cell type to stimulate the T cell response, but they can be cumbersome and costly to produce. So cognizant of that, and having a technology based on virus-like particles, we decided to deliver these virus-like particles with a little bit of GM-CSF intradermally, where the dendritic cells reside. The GM-CSF stimulates CCL3 production, which recruits more dendritic cells. And preclinical data, we were able to see that within 2 hours of intradermal injection, you could see DCs with the particles present in the draining lymph nodes. So one way to think about it is that this is essentially an off-the-shelf dendritic cell vaccine, very well tolerated throughout the studies that we've run. So this was the initial trial design, a pretty standard design. You can see there, starting from low, intermediate to high doses. I would have highlight the doses that we're using. Often you see people using 100 micrograms or more. These were very low doses, zero 0.4 micrograms, 2 or 10 micrograms of the PP65 antigen. So we had 6 patients in each study, in each cohort. We wanted to try to identify the optimal dose, and then cognizant that, with just a handful of patients in any cohort, we wouldn't really be able to see any kind of efficacy signals. So the plan was to, in part A, identify the optimal dose and then have an extension phase with an additional 10 patients to see if we could tease out any kind of signals. Now, in terms of the vaccine, it was very difficult for us to try to conceptualize or justify how many doses should be given. Is it 3? Is it 6? And the last thing we wanted was to have an instance where patients were doing well, and then because they had hit their arbitrary last dose, we stopped treating, and then all of a sudden they progressed. So for all the data you're going to see, patients were treated on a monthly basis until clinical disease progression. They received no other treatment during the study. I haven't highlighted the safety, but it was incredibly well tolerated. We didn't have any grade 3 AEs. We didn't have any kind of systemic effects, CNS effects. What you typically saw was a little bit of redness and sometimes some itchiness at the injection site, but otherwise very well tolerated. I won't share the data, but while we were running this trial, the former head of vaccines at GSK saw the data, was really intrigued. They had a very potent adjuvant called AS01 and asked if we wanted to explore their adjuvant with our particles. So we did evaluate it in an additional arm. The data looked quite good, but not better than what we saw with GM-CSF as an adjuvant. Perhaps not surprisingly, the highest dose proved to be the best dose in terms of disease response rate. So here are the data from parts A and B. These are all patients that received the same high dose, so 16 patients total. Now again, this is an open label study, and I think everyone's aware that there have been countless studies that have looked good in open label phase 1 and 2 studies, and then for those that did go on to phase 3, they've universally failed. And that's obviously because this is a heterogeneous disease. The patient populations are different, and so trying to compare against historical controls in terms of PFS or OS is quite challenging. So, when I highlighted this for management and for our investors, our board of directors, I emphasized to them that if we really think that this is working, you should expect to see some impact on the tumor itself. You should either see stable disease for a period of time or ideally see it shrinking. So this is the most objective data that we had. And what you can see here, those highlighted in black are patients that progressed very rapidly. You can see this is change in tumor size over time. This is weeks. And so you can see within a couple months, these tumors are doubling, tripling in size, hence, the very short median overall survival of around 8 months. Nevertheless, a handful of these patients, so 44%, 7 out of the 16, they did have tumor responses, either stable disease, so 2 consecutive stable scans, or partial responses that are in the solid symbols. Interestingly, one of these patients, the tumor actually increased by 50% after about 3 months. Then it stabilized, and then it converted to a partial response. This patient was treated monthly for over 2 years with a 93% reduction. So I think this had us encouraged, but in speaking with the neuro-oncologist, the question is always, okay, it's great to see an impact on the tumor cells, Dave, but what does that translate in terms of OS benefit for the patients? And so here you can see the swimmer plot on the right-hand side. And what I've done is I've color-coded, so those patients that had the tumor responses here on the left, they're highlighted in orange here in the swimmer plot. And what you can see is that there's a very nice correlation between those that had a tumor response and those that had a longer PFS or overall survival. And so you can see here the historical control, around 8 months. Here we're close to 13 months, so about a 5-month benefit. Here's an example of one of the MRIs. You can see here the enhancing tumor here, and then at 6 months you can see very clearly that we started to ameliorate that tumor. Now, as Alipi said, I'm an immunologist by training, and we never expected, unfortunately, that all patients would benefit equally, and wanted to try to identify any biomarkers that could help us guide the clinicians as to which patients would most likely benefit from treatment. So it was a pretty comprehensive panel. We looked at chemokines, we looked at cytokines in plasma, we looked at T cell responses, CD4 and CD8 by ELISpot, antibody responses, the GB protein, and here you can see a kind of primitive heat map. Those that had a tumor response here are in green, and it kind of sounds, no kidding, Dave, that makes complete sense, but you'd be surprised. No one ever thinks about the CD4 to CD8 ratio and how important it might be for an immunotherapeutic approach. In our hands, it really did correlate quite well, not perfectly, but quite well. You can see here, even given a very small n size, it was statistically significant. And just to put this in context, some of these patients had immune systems that looked like they had clinical AIDS in terms of just how few CD4 cells they had. In this assay, a healthy individual would have a ratio of around 3. So based on this data, collectively, we decided we wanted to amend the clinical protocol and have a randomized controlled arm, and we decided we want to give patients the best benefit, best chance to benefit from the vaccine. So we added an additional eligibility criteria for both arms, both standard of care and treatment with the vaccine, such that everyone had to have a normal CD4 count. So these are data from that trial. What you can see here, so I've color-coded it. Those that were treated with the vaccine are in blue. Those treated with standard of care are in orange. The standard of care was either lomustine or carmustine. Not surprisingly, we had quite a high dropout rate. Consent was withdrawn if the patients were randomized to the standard of care arm. Nevertheless, we did enroll, a fairly decent number. And what you can see is, the vast majority of patients in standard of care, they couldn't get past their first MRI, so they came off protocol, at 6 weeks. There were a couple patients that fortunately did benefit, shown here. And then what you can see in the blue is that many instances where the tumor initially increases in size, but they're clinically stable, and so per protocol, they were allowed to continue to get treatment, and then all of a sudden the tumor stops growing. In some cases, there's this nice slow, steady decline, partial response here. Another way to ask the question is, just in addition to looking at the tumor behavior and growth, how long are patients on protocol, as I just mentioned briefly a moment ago. And you can see on the right-hand side, the vast majority of patients on standard of care couldn't get past that one cycle. You had patients on treatment in the 1901 arm much longer. Now, unfortunately, so if you look at the data in totality, I'd said that when you looked at the open phase study parts A and B, The disease control rate, so standard disease plus partial response plus complete response, was 44%. In many clinical trials, vaccine trials in GBM, you have great results in phase 1, phase 2, and then you go to phase 3, and all of a sudden your active arm doesn't behave as well. In this case, it did. So it was 44% in parts A and B of the trial, and then 50% here, and that was higher than what we saw with standard of care of 33%. Now, unfortunately, for financial reasons, the company had to discontinue this trial. So this is kind of what we're stuck with. I think with the help and support of the treating neuro-oncologist, we are going to try to capture the median overall survival data and write this up, because I think this concept has been around, as I said, for over 20 years. There have been a lot of studies, but this is the first one to randomize and ask the question, would targeting viral antigens like CMV offer some benefit to patients with recurrent and primary GBM? So hopefully we will be able to get that data later this year and share it with the community. Now, this was alluded to earlier. This is primary GBM. You can see here in the middle, this is a blood vessel, so these are all red blood cells. You have T cells stained with CD3 in blue, and what you can see is that there are a lot of T cells. This is basically a perivascular cuffing. They leave the blood, but then they're just sitting there. The tumor cells are stained in brown, and you can see here on the right-hand side all these different tumor cells, but none of the T cells infiltrating. And so I think, asking the question, why didn't a greater number of patients benefit from the trial, because it was clearly a subset, I think this remains a huge issue that needs to be addressed in future trials. We may see some activity with cancer vaccines targeting glioblastoma, but if we want to get the full benefit and have it effective for a greater proportion of patients, I think we're going to need a combination approach that addresses the tumor microenvironment, because it is so immunosuppressive and it really hinders T cell infiltration. So just to summarize, I think collectively the data, especially now that we have some randomized data, do demonstrate that targeting the right antigen, immunogenic antigens like CMV, could prove effective, at least for a subset of patients with recurrent and primary GBM. As I just said, I think ultimately we're going to need a combination approach, something that addresses that immunosuppressive tumor microenvironment. I think most are familiar, but for those that aren't, the vast majority of the cells in a tumor that you take out are not tumor cells. They are myeloid cells that are incredibly immunosuppressive. And then finally, and this is our experience, and I think this is true for any small biotech that may be trying to develop innovative treatments for GBM, and true for academic designs as well. It's too easy to be fooled in open arm, single arm studies. We need to, keeping safety in mind first, move as quickly as possible into randomized controlled studies to understand what kind of signals we're seeing with new therapies on the horizon. So thanks very, very much for your attention. Happy to answer any questions you may have.
Can you hear me?
Use the big mic.
Thanks for that wonderful talk. And it's very exciting data. I think all of us here were very excited to have the trial and had some excellent responses in patients. You talked about combinatorial approaches that would also simultaneously target the tumor microenvironment. Were you talking about checkpoint inhibitors, or are there other agents that you would think about there?
Yeah, I mean, you might see some benefit if you combined it with checkpoint inhibitor, but I'd rather have a modality that really goes after those myeloid cells that are there within the tumor microenvironment to really try to address that aspect of the immune system. I think that would probably be more effective than just keeping the T cells on, because, as we just demonstrated, and this was emphasized by the previous talk, you can continue to vaccinate or infuse T cells. So even if they get turned off, you can overcome that. What you need to do is get them into that tumor microenvironment, and I think the barrier is really those myeloid cells.
Are there agents that you would think of for that purpose?
Yeah, and just full disclosure, obviously I'm working with Charles and another company, HDT, there in Seattle. They have some compounds that are able to kind of reprogram the myeloid populations from a kind of M2 phenotype, lots of TGF beta, IL-10, to something that is more pro-inflammatory, induces chemokine production to get more T cell infiltration there. So that's something. There are others that specifically try to deplete the myeloid cells. So I think there are some things out there now that haven't yet been paired with vaccines, and compounds on the horizon that could be very promising.
Thank you.